All right, good morning, everyone. I just want to go through a couple of housekeeping items before I introduce Dr. McKeon. First, you can find these recordings posted on this platform for 30 days after the conclusion of the symposium today. We're also posting these on the Office of Mental Health, and then we'll be posting those links to our SPCNY website, so you'll be able to watch them forever. All handouts are linked on the auditorium page next to each webinar link. And I just want to let everyone know, please use the Q&A tab for any questions you might have for Dr. McKeon. We'll try to get through as many of those as we can before the end of the presentation. It's a pleasure to welcome Dr. Richard McKeon for his presentation on a national perspective on zero suicide in healthcare. Dr. McKeon received his PhD in clinical psychology from the University of Arizona and has earned a master's of public health in health administration from Columbia University. He has spent most of his career working in community mental health, including 11 years as director of a psychiatric emergency service, 4 years as associate administrator, clinical director of a psychiatric emergency service, and 4 years as as associate administrator, clinical director of a hospital-based community mental health center in Newton, New Jersey. In 2001, he was awarded an American Psychological Association Congressional Fellowship and worked for United States Senator from Minnesota, Paul Wellston, covering health and mental health policy issues. He spent 5 years on the board of the American Association of Suicidality as clinical division director, and has also served on the board of the Division of Clinical Psychology of the American Psychological Association. He is currently chief of the suicide prevention branch in the Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration, where he oversees all branch suicide prevention activities, including the Garrett Lee Smith State Tribal Youth Suicide Prevention and Campus Suicide Prevention Grant Programs, as well as the National Suicide Prevention Lifeline, the Suicide Prevention Resource Center, and the Native Aspirations Program. In 2008, he was appointed by the Secretary of Veterans Affairs to the Secretary's Blue Ribbon Work Group on Suicide Prevention. In 2009, he was appointed by the Secretary of Defense to the Department of Defense Task Force on Suicide Prevention in the military. He served on the National Action Alliance for Suicide Prevention Task Force that revised the national strategy for suicide prevention and participated in the development of the World Health Organization's Suicide Prevention Report. He is also the co-chair of the Federal Working Group on Suicide Prevention. Now that we all know a little bit more about Dr. McKeon, I'll let you take it from here.
Thank you so much, Greg. It's a pleasure to be here today speaking with you all. And I will look forward to your questions. I'll try to leave a good amount of time. And when we get to the question and answer part, I'm happy to respond specifically about suicide prevention, or more generally about SAMHSA and federal efforts regarding suicide prevention and as well as crisis care. I know that you're hearing a number of great presentations. I think you've just heard from David Covington about 988 and some of the things that are happening in terms of crisis care. I will touch on that, but won't go into depth given the fact that you've heard David's presentation. I know that you've also heard from a range of excellent speakers as well and leaders. I may end up duplicating some of what they said, hopefully not too much, but we'll see how that goes. So I am now going to move to the next slide. I would also like to just take a moment to recognize my colleague and friend, Jenna Heiss, who's been a leader in suicide prevention for just about as many years as I've been involved. First in Texas and then coming, I would say, here to New York, but I'm not in New York. And I don't know how many of you are actually physically in New York, since we are all working together virtually because of the pandemic. And I would be remiss if I did not mention, SAMHSA and the federal government's concern about the mental health impact of COVID. it was because of that concern that SAMHSA actually initiated a specific grant program called COVID Emergency Response Suicide Prevention grants. We've awarded about 60 of those to focus on the mental health and suicide risk related aspects of the pandemic. The preliminary 2019 data, the preliminary 2020 data did not thankfully show an increase in suicide, but we have to wait to see what the final results are when they come in. But hopefully that will hold up. But we can't reassure ourselves too much because of those preliminary numbers, because we know that some of this may be having a cumulative effect, and there is concerning evidence about the impact on particular populations. The state of Maryland, for example, did a study during the pandemic that showed that suicide among whites was down, but suicide among Blacks was up. The CDC released a study several months ago that showed a very worrisome increase in young people being seen for suicide attempts in emergency rooms. For girls aged 12 to 17, the increase was about 50%. There was also an increase among boys of that age, but not as dramatic as among girls. So this means we need to pay attention to the impact of COVID on everyone in terms of mental health and suicide risk. But we need to be particularly aware of the impact on some populations that seem to be even at higher risk, particularly our youth. So I'm going to go to the next slide. This is our standard disclaimer. So what basically this says is that everything expressed doesn't necessarily represent SAMHSA's point of view. So if you don't like anything I say, please blame me, don't blame SAMHSA. And obviously the context, and this slide is a little old, but a couple of years ago, actually in 2018, the CDC released their vital signs report. And what this had shown was that suicide was increasing in almost every state, 49 of the 50, every state but Nevada. And Nevada had one of the highest suicide rates in the nation. So we couldn't take too much comfort in the fact that, Nevada's did not increase. We've been making substantial federal efforts, I would say with steady incremental increases in suicide prevention efforts over time. Now, our hope, because the 2019 data was the first year that suicide did not go up, and then it looks like that was maintained in 2020, despite the pandemic. So, our hope would be that the cumulative impact of all of the efforts that are being made across the country, and there's never been as much activity in suicide prevention as there is currently. But obviously our hope would be that these efforts are finally showing up in the national, statistics. We don't know that for sure, and the cumulative impact of COVID on that still remains to be seen. So we need to continue to intensify our efforts. And the Zero Suicide program, the Zero Suicide Initiative, is a very important part of that. So the Zero Suicide is integrated into the national strategy for suicide prevention, which is a revised version from the initial one published in 2001. More recently, and I don't have a slide on this, but more recently, actually in January of this year, the Office of the Surgeon General released a new call to action And what the call to action focused on was implementing the existing national strategy. So basically, when leaders in the public and private sector looked at where we were in terms of suicide prevention, came to the conclusion that it wasn't that we needed a new strategy, but rather we needed to be vigilant about implementing the strategy that we have. And in fact, the things that we know work, bringing them to scale. And one of those things was zero suicide, because the results are encouraging. And I know you've heard, about some of them as part of this conference. So the National Strategy for Suicide Prevention really has two goals that really encapsulate the Zero Suicide Initiative. And zero suicide is specified as one of the objectives in Goal 8 that encourage that healthcare programs explicitly adopt the goal of zero suicide. And as you may be aware, that has not been without controversy. People saying that, zero is an unrealistic goal. We're never going to be able to, to get there. But there are a number of reasons why zero is very important as the goal. The very name of the initiative, the Zero Suicide Initiative, is I could characterize it as it is an assault on the fatalism around suicide that has held us back, for many years, including in mental health components. And, that's probably because of some of the experiences that people have had where they may well have tried their best and lost someone to suicide despite that. I certainly had that experience as a clinician. And so the notion that suicide is preventable has many implications. It's not as straightforward as it may seem. Sometimes, family members who have lost a loved one think that when we talk about suicide as being preventable, that it meant that there was something that they should have been able to do to prevent it. And that's not at all what we mean. We sometimes talk about the preventability of suicide in too quick a way. So let me tell you what I mean when talking about suicide being preventable. Because when you look at Goal 8, promoting suicide prevention as a core component of healthcare services, and that implies that we can, in fact, prevent suicide. So one of the things that we don't talk about when we talk about the preventability of suicide is when we say that, who do we mean? Because we don't mean that somehow a family member or a friend or a colleague has it within their capacity to stop someone else from killing themselves, particularly when the intensity of suicidal planning and ideation, reaches its apex, which is often very soon before the death by suicide. And it also doesn't mean that a clinician can necessarily do that. A clinician can certainly take some, temporary steps, around that. Clinicians have a duty of care of using the best possible, evidence, but we can't always control the outcome. So what do we mean by the preventability of suicide? What we mean by that is that no suicide is fated, no suicide is predestined, no matter how high the risk, until the person takes that final fatal step, that there is always hope. that they can be averted from that trajectory, right? It's part of the reasons why working on access to lethal means is so important, because it may be that if someone is able to get through a few hours or even a few minutes of intense risk, that a suicide may be averted. But for healthcare to be effective in preventing suicide, then there has to be a strong effort within the system that focuses on that. Right? It can't be the individual efforts of a particular clinician. It requires a whole system's dedication to it, and that's what Zero Suicide is about. So I've not depicted all of the objectives under Goal 8. Goal 9 is closely related to promote and implement effective clinical and professional practices for assessing and treating those identified as being at risk for suicidal behaviors. And I don't know whether I think you have, or perhaps you're going to be hearing from Mike Hogan, who's instrumental in helping to craft these aspects of the National Strategy for Suicide Prevention. So a couple of things: that the 21st Century Cures Act, which was passed in December of 2016, signed into law at that time by President Obama, did a number of different things that were very relevant in terms of suicide prevention. It reauthorized the Garrett Lee Smith Memorial Act, which is our major program for focusing on youth suicide. It authorized in law for the first time the National Suicide Prevention Lifeline. But for our purposes today, I want to particularly emphasize that it authorized an adult suicide prevention initiative for the first time. And that adult suicide prevention initiative has led to the Zero Suicide grant program. And I'll talk a little bit more about that. It's not that we don't think that zero suicide is relevant for youth. In fact, as part of our Garrett Lee Smith grant program, we encourage youth serving agencies to be incorporating zero suicide as part of their efforts. And another report is from also established by the Cures Act, was an interdepartmental serious mental illness coordinating committee. They did a report to Congress, and that called for implementing zero suicide in all federal programs. And so SAMHSA has a significant grant program in this. We now actually have 35 zero suicide grants. New York was one of the first 3 to receive one of these zero suicide grants. So there are some that are not in here on this particular slide that now have them. Zero suicide is being implemented in an explicit program in the Indian Health Service. And the Air Force has also been implementing zero suicide as well. And other parts of the federal government are engaged as well. For example, a study on the sustainability of zero suicide and what's worked to help implement and sustain zero suicide has been conducted by what's called ASPE, which is the U.S. Department of Health and Human Services, Assistant Secretary for Performance and Evaluation. No need to remember that, but be aware that later this year, a report from them will be coming out that I've had a chance to review, and I think it really helps to identify some very encouraging efforts across the country. And you have probably heard most of this before, so pardon the repetition, but the idea that what Zero Suicide does is it makes suicide prevention a core responsibility of healthcare is, I think, hugely important. And conferences like this that are bringing together leading experts from around the country, showing how this can be done, is of particular importance. And we say it's a core responsibility of healthcare. It's really important that that's not misinterpreted as the responsibility of individual clinicians. For too long, but it's now changing with Zero Suicide, suicide prevention depended on the heroic efforts of individual clinicians or crisis staff to implement. And many, tried heroically to save lives and did save lives. But they were not backed up by a systematic approach within their system. And it's that systematic approach that Zero Suicide really works in, so that there's a protocol for care for people who have been identified at higher risk, that there is consensus about how to assess the risk and about the treatments that can be effective. So it makes suicide prevention a core responsibility, applies new knowledge and proven tools for suicide care. And we know much more about that, and we continue to learn on an ongoing basis. That it supports efforts to humanize crisis and acute care. And a key part of that is working to be able to have a collaborative relationship with someone to keep them safe. In the short term, non-collaborative approaches may help keep someone alive. But over the longer term, if we want to keep someone alive, we are much better off if we are working with the person rather than working, in essence, against what their wishes at that time might be. So it's an absolutely key part of suicide prevention is establishing a collaborative relationship, being able to identify where the intensity of the person's pain is coming from and how we can ally with them to have other ways of reducing their pain other than death by suicide. Zero Suicide, and again, you may have heard this, in addition to the national strategy, it's embedded in the Joint Commission Sentinel Event Alert. So there is much support and growing support throughout the healthcare system for these initiatives. So again, apologies if somebody else has shown you this slide. But this identifies some of the key components that there needs to be a pathway to care, so that it's not, if let's say an outpatient program has 12 different clinicians, that they're not all doing 12 entirely different things. Variability in healthcare is not a good thing, right? And it's not that everything needs to be the same, but variation can indicate some significant problems. And there is certainly room for individual judgment. We're not talking about some kind of cookie cutter approach, but there needs to be agreed upon guidelines for care, such as those that Zero Suicide provides, including around identifying and assessing suicide risk, what the approach is for screening, and then for those who, when screened, are identified as being at risk for suicide, an approach to assessment, and that they have access to evidence-based care. I presume that you probably heard a bit about safety planning, which I think is a very important intervention It's been studied in several controlled trials now. And what's important is that for years clinicians were relying on what were called no suicide contracts because we weren't providing them with anything better to utilize in working with people who were at high risk. And we know that no suicide contracts were not only not effective, there was some evidence that they were counterproductive because patients, in some sense, accurately perceived they were more about the clinician or the system's desire for protection from liability than it was about them and their pain. And of course, it wasn't effective to protect against liability either. And then other kinds of evidence-based care, restricting access to lethal means being absolutely key as part of that. And if you're not aware of it, the Suicide Prevention Resource Center has an excellent online course called Counseling on Access to Lethal Means. And that is really focused on the outpatient setting. SAMHSA recently provided support to the Suicide Prevention Resource Center to develop an adaptation for crisis services. But that's probably a year or two away. And then another key piece is treating suicidality directly, as well as the underlying mental health problem or mental illness, whether that's depression or anxiety and eating disorder. So while those conditions, they need to be treated, it's important that suicidality specifically be treated as part of that. And the psychotherapies that we've seen that now have substantial scientific support for their effectiveness is all share that characteristic of treating suicidality directly. And then staying connected to people, providing continuous support. Kay Redfield Jameson, in her book, Night Falls Fast, said that the gap between, and referring to suicide, that the gap between what we know and what we do is lethal. But there are also lethal gaps within our systems of care, and that continuous support and contact when people are identified as being at high risk. So a lot is important. And some of the places doing zero suicide, can tell very compelling, stories, individual, anecdotes, but compelling nonetheless, of people who were on a high risk pathway, not showing up for an appointment, and, the system being set up so that that person could be reached out to. And at least in several instances where we know it was that intervention was life-saving, because we paid attention to that continuous, support. And so continuity of care is a really important part of this. There are a lot of efforts to make this easier for clinicians by integrating into electronic health records. And then these various interventions need to take place with support from leadership within a safety-oriented culture, and with focus on developing a competent, confident, and caring workforce, which means that people need to be trained. And our training programs nationally have typically not required training in suicide, which is a weakness that has been identified in the national strategy. I often tell the story about how when I was in graduate school, in an American Psychological Association approved program at the University of Arizona in clinical psychology, and when I was a psychology intern at Yale, during that entire time, I was only exposed to one lecture on suicide or suicide risk. I was treating suicidal patients, and we did talk about them in supervision. The irony was that the one lecture I heard was the one lecture I gave, because we had a psychopathology teacher who said, pick a topic and present to the class. So I picked suicide and presented on it, and that was it. No one else in my graduate education or my internship ever presented anything about suicide. So that, now I think that's getting better. Some states now mandate training. California has mandated that for psychologists. The state of Washington is another example. Kentucky was an early leader, in this. So it's hugely important as part of the zero suicide efforts. And then the idea of continuous quality improvement, that we are constantly looking at what we're doing to see how we can improve. New York has done something similar, but I've also been tracking on developments in Colorado. And in Colorado, a Medicaid quality improvement incentive program has led to a really significant increase in the adoption of zero suicide in hospitals and healthcare systems across the state. And I think that New York has utilized some similar mechanisms, if I understand correctly. And one of the things that we have tried to do as part of zero suicide is to try to have an understanding, to have some way of tracking on, are we losing people that we're treating? Are we looking at the deaths by suicide and suicide attempts, not from a punitive way of who did something wrong, but to try to identify what the system may be able to do better. We owe it to those we've lost and their loved ones to have the mindset that we are always striving to improve. And we can only do that if we are carefully looking at those who we do lose, and providing support to clinicians who have experienced the loss of someone that they were trying very hard to help keep alive and to have, in Marsha Linehan's words, a life worth living. Now, this references our youth suicide prevention program, but I'm showing it to you just so that you know that as part of SAMHSA's Garrett Lee Smith work, we've shown that counties that have implemented our youth suicide prevention grants have lower rates of youth suicide than matched counties who are not. Further research has shown that it's directly related to the years of continued funding, which means that, this is something we need to continue to work on. Now, our zero suicide grants, and said we currently have 35 zero suicide grants in the field, have just begun in our last 2 iterations as a requirement of the grants to be reporting on deaths by suicide and suicide attempts. So that, and again, not in a punitive way, but with a focus on quality improvement. Centerstone, for example, has been doing this over a period of years. Henry Ford has been doing this over a period of years. Centerstone found, for example, that the people that they were losing in their system were, by and large, not the people who had been identified as being at high risk. So they found that folks who were medication-only patients there, so they initiated some changes. That's the kind of thing that we're talking about. Looking at what we can do better, constantly striving to improve, and using data for quality improvement. Now, one of the things that is very different now than from years past is the availability of high quality screening tools. Not only the availability of screening tools, in the old days, someone might use like the Beck hopelessness scale, and you would have, maybe 30, 40, 50 in a research study, because that was all that could be done. We now have folks using things like the PHQ-9 with, millions of administrations that are then able to look at things like the ability of the PHQ-9, and particularly question 9, which is the suicide specific question, to indicate suicide deaths or attempts. And a couple of things, and Brian Amadani may well mention this as well, and Greg Simon done a lot of research in this area. Sometimes folks use the PHQ-2, and the problem with that is that if you don't ask the suicide question, there's some people who will not look like they have elevated depression on questions 1 and 2, but would answer yes to 9 regarding suicidal ideation. And of course, the worst thing to do is to do the PHQ-8, but the PHQ-8 is the PHQ-9 dropping the suicide question. That's like an advertisement that, that's like putting on the medical chart, if this patient's suicidal, we don't want to know. So I would strongly advise against, ever using the PHQ-8. It's not an official designation, but some places have in fact done that. Many of you are aware of the Columbia Suicide Severity Rating Scale, which can be used both as a screening version, but also as a more detailed assessment. And this has helped us look at some, important areas as well to our attention. For years, we've talked about suicidal ideation, suicide plans, suicide attempts. And oftentimes in medical records going back for years, you would see no SI, sometimes no SI plan or attempt. And those are important, but doesn't capture everything. Somebody preparing for suicide, making active preparations, really taking any kind of action likely indicates particular risk. Even if a suicide attempt doesn't occur, right? So it's that kind of planning and preparation is very important to be aware of in terms of suicide risk assessment. This is from the Zero Suicide website, and lots of information about safety planning there. Barbara Stanley is clearly a national leader, based in New York, working with a lot of folks in New York around safety planning, working with the Veterans Administration around safety planning, and elsewhere. I mentioned this before, counseling on access to lethal means is a key component as well, particularly because, there's some indication that while suicidal ideation, let me put it this way, when someone kills themselves, it doesn't come out of the blue, with just a few minutes notice. That's extremely rare. There's usually periods of preparation and kind of building up to taking that final fearsome act. But it does appear from some of the research studies that what happens is that while a person may have thought about suicide over a period of time, maybe put it out of their mind, then maybe have those thoughts come back again, that in the last days before a suicide attempt and death, it starts to intensify. The planning and preparation starts to intensify. And sometimes the time interval between the final decision about killing themselves and taking the action can be very short. And that's where access to lethal means can be critically important. As you all know, the majority of suicides, maybe 52% or so, use a firearm. So safe storage of firearms is something that is hugely important, so that in a moment's vulnerability, it's not easily accessible. This is a SAMHSA tool. Doug Jacobs originally developed this, called the Suicide Assessment 5-Step Evaluation and Triage. It's a wildcard available on the SAMHSA website. And it kind of walks a clinician through doing a suicide risk assessment. I'm not going to go over it in detail in the interest of time. This is now an app that is online called the Suicide Safe app. It's available both in Apple and Android stores. The SPRC has a course on assessing and managing suicide risks. This has recently been adapted for substance abuse providers as well. And I mentioned before, a key component of zero suicide is treating suicide directly. There are now multiple randomized controlled trials showing reductions in suicidal behavior that all focus directly on suicidality, dialectical behavior therapy, of course. Versions of CBT have been developed both for the civilian and military. CAMS, the Collaborative Assessment and Management of Suicidality, and then a program called ASIP, which was developed in Europe and showed that a brief intervention could significantly reduce suicide attempts. It's now is being done in replicating that in the United States. There's a trial showing that CBT for insomnia can reduce suicidal ideation, and insomnia itself is a risk factor. This is just a picture around the Collaborative Assessment and Management of Suicidality. This is the ASIP manual. So these treatments exist. And obviously people need to be trained in it. We would wish that everyone was trained when they're in graduate school, but that's not the case. And so mental health care and healthcare systems need to find ways to be able to provide some of this training, because oftentimes clinicians were not getting through various kinds of continuing education and so forth. Improving care transitions, I've mentioned, before, particularly when people are leaving inpatient units and after emergency rooms. There was a major study that came out within the last year showing that kids who were seen within 7 days after discharge from inpatient psychiatric units had lower rates of death by suicide than kids who were not seen within the next 7 days. Major studies from California showing high rates, a 56 times rated increase following emergency department discharge for those who attempted suicide over the next 12 months. But most of our systems don't have, are not set up to provide continued contact and care, even though there are now several controlled trials showing that follow-up phone calls combined with safety planning can reduce suicide attempts. The fact that this has not been implemented in healthcare systems across the country is a major failing in our current system. The Veterans Administration is explicitly trying to implement this across the VA following, after having looked at the results from what's called the Safe Death Study. And mortality after recent suicide attempts is a critical issue as well. I'm not going to, I've talked about that in terms of continuity of care. SAMHSA has looked at that from some of our NSSP data and found that particularly for men with less than a high school education, extremely high rate of death by suicide in the year following a suicide attempt. And very few had actually had outpatient mental health treatment, or at least a minority. And so structured follow-up and monitoring for suicidal individuals, a key component of zero suicide. Okay, I'm almost to the end of my talk, and then I'll be certainly willing to answer any questions that you have. The availability of the National Suicide Prevention Lifeline, as you've heard, that is transitioning to 988. However, the 1-800-273-TALK, 1-800-273-8255 number is what everyone should call until July 22. And the reason is that only at that time will everyone have access to 988. But also be aware that this number, 273-TALK, is not going anywhere. It will continue to operate, will continue to be available for the foreseeable future. So that's important to be aware of. Because people need, whether it's calling a crisis hotline, the National Suicide Prevention Lifeline, a local hotline, there needs to be availability after hours. as a key part of suicide prevention. So each system needs to be thinking through how that around-the-clock availability can be done. Obviously, no individual clinician can be available 7 days a week, 24 hours, but systems need to make sure there is availability. This is some research from Dr. Gould at Columbia, showing how follow-up calls were perceived by the individuals, both callers as well as hospital clients, as having stopped them from killing themselves, either a lot or a little. And of importance, virtually no one said that these kinds of follow-up calls had a negative effect on them. The National Suicide Prevention Lifeline has an imminent risk policy. We've also studied this as part of our hotline evaluations. Dealing with people at imminent risk obviously happens not only on the nation's hotlines, but also in community mental health centers and in healthcare settings across the nation every single day. And so having a policy around imminent risk, one that emphasizes collaboration whenever feasible, is really important. This shows you some of the work that's been published about some of the interventions that have been used to try to maximize less invasive and collaborative. And so I would call your attention to Dr. Gould's work in this area. I'm not going to go over this in detail because I believe you heard about this from David Covington around the Crisis Now model. But this slide is part of what I'm going to end with. And this really has to do with the issue of continuity of care and the responsibility of systems of care to do a better job providing follow-up and staying in contact with high-risk individuals. And, so this slide emphasizes that, ubiquitous and inexpensive technology is changing nearly every other industry. And at a time when we can track a package halfway around the world, it should be unacceptable in the United States of America for us to lose track of people at high risk for suicide within the lethal gaps in many of our systems. And it is transforming this system that SAMHSA is committed to in terms of our crisis systems, but also in terms of zero suicide, in terms of linking people to high quality care that can provide state-of-the-art and state-of-the-science care. And that the care that we provide is linked to a well-functioning crisis system that can help maintain collaboration whenever possible, stay in contact with people until they're linked to care, and work closely with our outpatient providers and other community resources. So I'm going to end there, and we can open it up for questions. This is how I can be contacted. I'm certainly happy to respond to emails. So I will give it back to you, Greg.
Thank you so much, Dr. McKeon. Really appreciate your presentation. We do have a couple of questions right off the bat here for the next couple minutes. Number one, would you please review the trainings and apps again?
Yeah, well, there are, so regarding the apps, there are loads of apps that are out there now, for sure. And I've not tried to review all of them or to comment on their quality, but the one that SAMHSA itself has developed is called the Suicide Safe app, and it's available in the both the Apple and Android stores. And what it basically does is it walks through the safety card, and go back to it. I don't hope to not make anyone dizzy. So this is what it puts in the form of an app, that suicide assessment and 5-step evaluation and triage. So this is a pocket card that walks a clinician through doing a suicide risk assessment. It's a very handy tool. And what SAMHSA did was to take this product available on the SAMHSA website, developed originally by Doug Jacobs from the American Psychiatric Association in collaboration with the SPRC. And we've taken this information and we put it in the form of an app. So it's now in the form of a wallet card, but also in the form of an app that you can download. There are many trainings out there. Some are very specific to particular treatments. So there's DBT training, there's CAMS training, et cetera. So people can learn particular treatments. There are also other community gatekeeping approaches that are used widely: question, persuade, refer, assist, done by LivingWorks. And some have developed approaches that are specific for use of providers. The SPRC has some information, as does the Zero Suicide website, on a variety of different trainings, that are available. And I think what's most important is, and I think each organization has to decide what training is most helpful for them. A lot have utilized CALM because it's an online training, counseling and access to lethal means, that can be utilized in a wide variety of circumstances there. So we could easily do a whole plenary just on training. But the SPRC website and the Zero Suicide website does have more information.
All right, thank you. Our next question is, organizationally, what do you consider the #1 most important step behavior healthcare institutions can take to embark on a comprehensive suicide prevention plan?
That's a great point, because there are so many, that are key. So I don't think I can just identify one, but certainly leadership buy-in is important. Clinicians working in a system need to hear from leadership. I think it's also vital that the efforts, and I mentioned quality improvement as one way, and using data, but another piece that's critical is utilizing feedback with people from lived experience, what they felt helped them, and what they felt did not help or might even have been harmful. So incorporating those voices and planning an effort is really important. That Becky Stoll from Centerstone frequently said this: zero suicide is a marathon and not a sprint. That the multiple components can't all be implemented at the same time. Personally, I think that one of the key things in terms of what needs to be done programmatically is developing a protocol for care. So when you've identified someone as being at risk, what are the key components of their care? What are they going to be offered? And it doesn't have to be just one form of psychotherapy. I think that that's key, and that people are talking about what that protocol should look like, what other places are using as part of their protocols, so that an individual clinician can feel like there is support around them for how they should work with somebody who's at high risk. Because we're all very anxious when we're working about losing someone, when we perceive them as being at high risk. And the clinician should not be isolated in that. There needs to be support around them. So I know I didn't just give one thing, but those are several things. But the different components of zero suicide do need to be sequenced. And every system has identified some people at high risk. So I think you can start with a protocol and then move to how to get better at identifying people at high risk. So to have a screening protocol where people are routinely asked about whether they're thinking about suicide, et cetera.
Thank you. And our next question: it seems sometimes suicide assessments and referrals are fear-based. An example, not wanting to get in trouble, or if something happens, or referring to an ED just to be safe. how do we move away from fear-based suicide assessments and towards more effective and evidence-based assessments?
I mean, I think that that question, that's exactly accurate. That's a huge part of what the problem has been. And, I think that that's fueled by anxiety and fear, as you say, fear about losing a patient, I think primarily, but also about liability that may go with that. Because if a clinician is working with somebody who's thinking about suicide, there's no reason for that person to have to go to the emergency room. When I worked in New Jersey, even in our emergency service, we would not send somebody to the emergency room whenever the mental health center was open. We saw people in our offices, and it was rare that was not, sufficient. It was only perhaps if somebody was intoxicated or perhaps they were highly agitated as well as being suicidal that they'd be sent to the emergency room. So that's not needed, but it is kind of an anxiety-laden default in many places. But I think part of the protection about that can be if you have a protocol, what can protect as far as liability and provide some reassurance for the clinician is being able to work within a protocol that that gives them some help, some instruction, some scientifically based consensus about how to proceed. Because the reality is, there's no randomized controlled trial that shows that forcing somebody to go to the emergency room and then hospitalizing them against their will, potentially, for a short period of time, will actually save lives. And if we were able to do, which we never have been studies, what we might find is that there might be a short-term gain in terms of lives saved, but it may have a long-term cost. We may be inadvertently teaching people to never talk to their clinicians about suicide if they can anticipate. So discussions about suicide basically have to be part of a caring conversation in which the patient can experience the clinician as being concerned about their pain as well as their safety, right? So it can't be a rote exercise. But getting to exactly that place where patients don't have to be routinely sent to the emergency room if they mention the word suicide, which we can, if that's what their experience is, we can anticipate the next time they're in a room with the clinician, if they're thinking about suicide, they're not going to tell us. That's pretty rational to not do that. If you don't want to be brought to the emergency room and you don't want to go through that experience, then it's rational to not share that. We don't want to have incentives in our system for people not telling us about their suicidal thoughts. We want to have incentives in our system for people being willing to tell us. And when I worked in New Jersey, part of what we used to communicate to patients is that we're not going to hospitalize you because you're thinking about suicide. We're not going to do anything against your will because you're thinking about suicide. So the only time we'll do that is if, based on what you're telling us, we think you are about to act on suicidal thoughts and you're unwilling to work with us on keeping yourself safe. So we were very straightforward and transparent about how we approach that.
All right, well, thank you so much, Dr. McKeon. It looks like we covered all of our attendees' questions for this morning. I want to thank you again, really appreciate it, and thank everyone for joining us today. Our next presenter is Dr. Brian Amadani, who will be presenting Implementing Zero Suicide in Health Systems. So thank you again, Dr. McKeon. Really appreciate your time.
Thank you. It's been a pleasure.